Post-MI survivors are very large heterogeneous group. Every patient is different. There are patients who may die within few weeks. There are patients who may not die for next 10 years. So risk of cardiac events after MI like recurrent angina, myocardial infarction, heart failure, certain cardiac death, they need to be evaluated in each and every individual if they survive myocardial infarction. Risk stratification is vital because once we do that, we are able to apply the best available preventive or therapeutic strategy in that individual person and in this very vulnerable population. There are clinical variables. We know that younger than 45 years have low mortality at 1 year, 5 to 6%. If you are above 80 years of age, very high, 30 to 40% mortality 1 year has been documented in the literature for a long time. Location of MI, anterior versus inferior versus non-STEMI, spontaneous ischemia occurring within 24 to 48 hours after successful angioplasty or thrombolysis, LVF, congestive heart failure, cardiogenic shock, complex arrhythmias, history of previous myocardial infarction, presence of diabetes, presence of CKD, they all are the clinical variables which can tell you that these patients are going to behave badly and worse than the other patients. So basically we are looking for three important things in the post-MI phase. Left ventricular function, which is the most important determinant of outcome, immediate following MI as well as in the long-term outcome. Residual myocardial ischemia and ventricular arrhythmias. So when we are talking of risk stratification, we should focus on these three items in every individual. As far as left ventricular function is concerned, we have known for a long time that lower is the ejection fraction versus the outcome, to the tune that if it is below 20-25%, you are talking of 30 to 40% mortality at 1 year, as against less than 5% mortality if it is normal or near normal. Residual myocardial ischemia is very important, which may not present clinically as angina, but frequency, severity, magnitude of ischemia at any given level of LV function or at any given extent of severity of CAD. Two patients may have same LV function, same severity of coronary artery disease, but one having ischemia, one not having ischemia is totally different patient. So residual myocardial ischemia put together with LV function and with the severity of coronary artery disease is what determines the outcome. Now ECG stress test is very important. Conventionally, the treadmill test has been done, and positive post-discharge stress test predicts 2 to 15 folds higher chances of having cardiac events and up to 25% mortality at 1 year, as against just 3% mortality at 1 year if the post-discharge or pre-discharge stress test is negative. Now there are exercise responses which also predict that patient may have a multivessel disease or left main disease, and they are all there in the literature. We have been seeing this for a long time. Down-sloping ST depression more than 2 millimeter, early onset ST changes, prolonged duration of ST depression, and complex ventricular ectopy at the lower heart rate during exercise test. There are non-ECG variables during the exercise test, which is low achieved heart rate, hypotension during exercise test, failure to increase systolic blood pressure of more than 10 not beats, it's 10 millimeter systolic, low achieved heart rate, blood pressure product less than 15,000, and inability to exercise more than 3 minutes on the Bruce protocol. Now, imaging mortality like stress echo or radionuclide studies should be added in these patients who have resting ECG abnormality, like if they have resting ECG showing more than 1 millimeter ST depression, if they have left ventricular hypertrophy, Bundelbranch block, intraventricular conduction defect, pre-excitation, or digoxin therapy, who are able to exercise and who have these abnormalities, the either stress echo or radionuclide testing should be advocated. Pharmacological stress testing is mainly for those people who have physical limitations like arthritis, amputation, peripheral vascular disease, chronic lung disease, and general debility. And now obviously they cannot do the exercise testing. The choice of stress test is based on the resting ECG, ability to perform exercise, local expertise, which is very important, and technologies available to you. Treadmill exercise test is useful in patients who have no ECG abnormality except Q wave, no ST abnormalities, no bundle branch block, hypertrophy, IVCD, and these resting ECG abnormalities. Non-invasive stress testing is recommended in low-risk patients and in the intermediate risk patients. It's not recommended in high-risk patients if you are able to judge that they are high risk on the clinical variables. So just to summarize the how do we interpret the stress testing, stress radionuclide ventriculography, exercise ejection fraction less than 50%, resting EF less than 35%, and fall in ejection fraction of more than 10% in radionuclide ventriculography is suggestive of a high risk post-infarction. Stress echocardiography, resting ejection fraction less than 35% or wall motion score more than one segment. Instead, radionuclide myocardial perfusion, abnormal myocardial tracer distribution, cardiac enlargement, and myocardial distribution with the increased lung intake. So these are the interpretations of various post-MI stress testings. Now, detection of arrhythmias and risk of sudden cardiac death is fairly high in patients who are at high risk of events. 4 to 8% survivors of MI do get sudden cardiac death in the first year. Now, mind it, residual LV function is the most important determinant of sudden cardiac death, much more than the arrhythmias. So if you have a very low ejection fraction, low LV function, you are likely to have sudden death irrespective of whether you get arrhythmias or not. Ambulatory monitoring, extended loop recording, signal average ECG, heart rate variability, electrophysiology study. I'm not going to discuss in detail, but we all know that these are the various tools used to be popular in the previous years. But then I think currently we only use Holters, ELRs, of course electrophysiological studies in a very specific cases to just the need for the the ICDs and all. But end of the day, it is the residual LV function which determines, and that's why the primary prevention of sudden cardiac death has been focused on the low ejection fraction, irrespective of the presence of arrhythmias. Who should undergo coronary angiography? There are various thoughts, various concepts. Probably everyone after MI. Many people don't agree. Primary PCI contemplated, of course, they will undergo rescue PCI, ongoing chest pains with or without lysis, post-MI angina. I mean, these are the groups where there is absolutely no doubt that everybody would agree for coronary angiogram. But then, there are reasons to think that with the ease of these tests, many low-risk patients can be identified very early, or very high-risk patient can be identified with angiogram to get the proper therapy. So just to summarize, low risk, intermediate risk, and high risk individuals should be separated, right after the myocardial infarction. I'm only reading this slide because high risk is what is most important. Severe resting LV dysfunction, severe exercise-induced LV dysfunction, stress-induced large perfusion defects on radionuclide imaging, stress-induced multiple perfusion defects of moderate size, large fixed perfusion defect, stress-induced moderation defect with LV dilatation, echocardiographic abnormalities, and stress echocardiographic evidence of extensive ischemia. Thank you very much.